Yes, hello. Good afternoon to everybody. Thank you for joining this online lecture. My name is David Schwappach and I'm the Scientific Director of the Swiss Patient Safety Foundation. In my lecture, I'm going to talk about the scope of safety problems in cancer care. I'll show you some recent data and suggest some general strategies for improvement. Please remember that you can send in questions and comments at any time. We will discuss them at one point in a break during the session and at the end. Okay, so let's start. I want to start with highlighting the incredible advances cancer care has made during the last decades. If we look, for example, at the data from the UK, you can see that cancer survival in England has doubled in the last 40 years, which is really a large-scale success, I think. But during the same period of time, we have seen an important other development, and that is a considerable rise in the complexity of cancer care. Complexity here refers to complexity within therapies. For example, the number of therapies, drugs, regimes, application routes, the scheduling of regimes and treatments, complex dose calculations, for example, including body surface area. We come to that particular point later. Comorbidities, co-medications, and so on. But maybe even more important for patient safety is the rise in complexity in the organization of care. For example, job specialization, the fragmentation and division of work we see, and increased numbers of frequent intra and intrasectoral transitions of patients, for example, between the outpatient and inpatient setting, between GP and other providers. And of course, we have seen new technologies over the last years and decades, like new devices and, of course, the entire topic of digitalization. So complexity translates to a higher number of processes, interfaces, information, coordination requirements, compatibilities, communication, interaction. And complex systems are characterized by specialization and interdependencies. And that's what makes them prone to error. And this is, I want to emphasize that this is despite highly educated and motivated staff caring for patients. So I want to show you a really everyday example. This is an example we obtained in a qualitative study where we observed nursing safety processes around administering chemotherapy. And this nurse is, I'm going to show you in a couple of seconds, is working in a Swiss university hospital at the ambulatory infusion unit. Her task is to double check the prescription against the drugs delivered from the pharmacy before preparing and administering the chemo. She has two sources of information which she needs to compare. The prescription paper printout, which comes with the delivered medication, and the drug labels. And she reports, here on the prescription sheet, only the data at the top are valid. All these blocks of information at the bottom, they are always wrong. I have to ignore them. They have a different computer system on board and the therapy schemes are stored differently. With every prescription, I have to imagine that away, disregarded. As you can imagine, and I think many of you will share similar experiences, this is intense mental work done by the nurse. It is completely unnecessary and with high potential for error. I think it's a very good example of how poorly designed the systems of care provision are. Literally speaking, we are providing high-tech therapies in antique garments. And As a result, the harm associated with healthcare is considerable despite the advances we made in cancer treatment. Let's have a closer look at the safety problem. For those of you not so familiar with patient safety terminology, let me just briefly turn to two important terms: errors and adverse events. The main distinction between these two concepts is that adverse events always involve patient harm, whereas errors don't. An error is the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. Human error, that's an important note, is a judgment made in hindsight. And errors may or may not result in adverse events. The majority of errors does make no harm because they are intercepted before reaching the patient. Adverse events, on the other side, are unintended injuries caused by healthcare management rather than by the disease process, and include acts of omission, which are often much more common than active errors. Adverse events may or may not be preventable, and adverse events due to errors are deemed preventable. And these preventable adverse events are where in the Venn diagram you see on the slide where the adverse events and the medical errors overlap. Research into adverse events and errors in cancer care have mainly focused on medication safety and chemotherapy safety in particular. And here, the distinction between error and adverse event is really important because, for example, prescription errors are often identified and intercepted by pharmacy services. So we have a large number of errors, but only a small number of adverse events. So let's have a look at the incidence of medication errors. This study addressed medication errors in adult and pediatric patients in the outpatient setting, and the authors used record review to identify errors, and two physicians independently judged whether an error occurred and identified its severity and consequences. And as you can see from the table, from the red circles, errors occurred in roughly 1% of medication orders. And very roughly, again, 10% of these errors resulted in injury, and 1% of all patient visits resulted in error with injury. In this study, administration errors were often due to confusion over two sets of orders, one written at diagnosis and another adjusted dose on the day of administration. And this is a very common problem we see in a variety of manifestations, the coexistence of different information and data. Let's turn to an important subgroup of errors, that is prescribing errors. And this is a very important study conducted in Sweden just 2 years ago. And they addressed non-intercepted dosing errors that reached the patient. And that's so important and valuable in the study because the researchers identified wrong doses that were actually administered and not intercepted. So patients received these wrong doses. The researchers recalculated doses according to the guidelines of each participating institution using patient data documented in the patient record, paper prescription form, and so on, and defined non-intercepted prescription dosing error as a more or equal to 10% difference between the administered and the recalculated dose. And they found that the risk of a non-intercepted prescription dosing error of 1.7 per 100 prescriptions, well, is that high or low? Imagine if all your currency conversions you do for holidays, nearly 2 of those conversions out of 100 would have a more than 10% difference in what you should receive and what you actually receive. You should actually receive 100 pounds and you only get 90 pounds. that's probably not a very fair deal. The greatest risk for errors in this study were complex dose calculations, those that included body surface area and GFR, and for example, a failure to recalculate dose despite more than a 10% change in body weight. As I mentioned, the studies on medication errors are very important, but they do focus only one aspect of therapy. They do not tell us about the whole risks patients are exposed to during the course of treatment, which may also involve, for example, radiotherapy, surgery, and other treatments. And a recent study just published a few months ago, it's very important because it's a wider focus than just medication errors. In this study, adverse events across inpatient and outpatient settings were assessed over the course of 1 year. And patients with breast, colorectal, and lung cancer were included in this study. And they used a trigger tool including 76 triggers or signals that would lead reviewers to a focused review of the record for the occurrence of adverse events. Examples for such triggers are return to the operating room or interventional radiology within 30 days or elevated blood glucose levels. During the 1 year observation period, 1/3 of patients had at least one adverse event, 16% had at least one preventable event, and 4% of preventable adverse events resulted in permanent harm or death, like lymphedema, abscess, or renal failure. Okay, let me remind you that you may send in questions and comments. So far we have looked at the frequency of errors and adverse events identified by researchers or physician judges. But what about those involved in the care process? What about patients and their healthcare staff? Are they concerned for safety? And the simple answer to that question is yes, they are. We conducted qualitative and quantitative studies among Swiss chemotherapy patients in 2009, and we did a survey and many interviews. And among other things, we asked them for their experiences with medical errors and their perceptions of safety. And our results, you see the numbers on the chart, clearly show that medical errors and patient safety are important issues for patients. And a considerable fraction of patients is currently somewhat or even very concerned about errors in their care. And it's worth noting that those who feel they have experienced an error are very much more likely to be concerned for future errors with an odds ratio of about 12. So we are turning now to the staff involved. Are they concerned about safety as well? And we conducted a study in Switzerland 2 years ago and surveyed nurses and doctors from 9 oncology units in Switzerland. And we found in this study that safety concerns were very common among responders, with every second nurse and physician recognized their colleagues making potentially harmful errors at least sometimes. 40% said they see violations of important safety rules at least sometimes. 4% reported that they see that very frequently. We also found that some groups of staff reported higher frequencies of concerns, in particular nurses versus physicians. Nurses were much more frequently concerned about rule breaking, for example. Staff without managerial functions were more likely to report concerns compared to leaders and managers, clinical managers. And interestingly, staff working on wards were more likely to report concerns compared to healthcare staff working on ambulatory units. In interviews, the staff reported a very broad range of events which raised their concerns. For example, missing written orders, not complying to hygiene standards, not complying to prescription standards required in that institution, wrong use of forms, of prescription forms, for example, and so on. So we saw a very large scale of events that were reported by nurses and physicians in that study. Okay, now we have seen the range and severity of problems. I'm going to talk about strategies for improvement later on, but I want to ask my dear colleague Elliot in Cardiff whether there are any questions we should discuss now at the moment.
Thanks, David. There are no questions at the moment from any of the participants. I've got a quick question to ask, if that's okay, which was the interesting point you made on slide 14, differences in professional reporting rates between nurses and physicians. Sorry, on slide 15.
Yeah, that's okay.
What do you think the root causes are there in terms of those differences, possibly?
I think it's probably two. The first is nurses are probably more likely to report their concerns. We see that, for example, also in incident reporting systems where nurses are much more likely to report any events compared to physicians. We know from these studies that physicians need like a higher level of severe events to file a report than nurses do. So they might just simply have a higher likelihood of reporting their concerns in our study. But I also think they are in fact more concerned because, for example, many of the daily safety concerns nurses have relate to non-compliance with procedures. And I have to say that it's usually doctors not complying with procedures in the sense nurses expect them to, for example, hygiene standards. And I learned in this study that obviously nurses and physicians often have quite different ideas of what is important for safety. And I think a really good first step would be to discuss these differences in perception, because it's, to my point of view, it's not good if nurses have severe concerns and the other professional group is not even aware of these concerns. So it would be valuable to talk this over, I think.
Yes. There's one question that's just come in about differences across Europe where the nursing role can vary a lot. I can certainly testify to differences in professional roles within nursing. So yeah, how do you think these results might, so this study was done in Switzerland.
Yeah.
So any views on that, David, in terms of you also have insight into other countries?
I think as far as I know from other European countries and as far as I know data from the US, the relation between nurses and physicians, for example, in having concerns and reporting concerns is probably quite similar across the countries, I think. I think there are differences in what they do with their concerns. I will return to that later on, but I think in healthcare systems where there's a steep hierarchy between nurses and physicians, for example, nurses will be less likely to speak up, to mention these concerns, to file a report or whatever. Whereas in healthcare systems with steeper hierarchies, or lower hierarchies, nurses will probably talk to their colleagues and have a lower threshold of withholding their voice, probably. That's what we know from the data. It has also to do, I think, with the roles nurses have. For example, are they specialized for oncology? Do they have a special education, a special training? And if they have, we often see that they are quite good champions for safety, for example, because they have an important role in ensuring safe care.
Yeah.
If they are not so specialized, then usually they're simply weaker and standing up for safety.
Yes. Yeah. And there's a follow-up question around autonomy of the nurse's role, and I think that's an important difference across countries as well, globally. And what you said there is you've already touched on it. I think in terms of specialized roles versus less specialized roles vary across the world, and I think speaking up varies accordingly, really.
Yeah. Yeah, I agree. I've often asked whether I think that speaking up behaviors are different in Germany as they are in Switzerland, for example.
Yeah.
And of course, hierarchy and autonomy plays an important role in speaking up and being a champion for safety and caring for patients. But it's sometimes I think it's not as easy. In countries where we have very small teams, for example, very, very small groups of staff. We have hospitals in Switzerland where only 5, 6, 7 people are working together. And they often feel like a family. And they know each other very, very well. And sometimes that doesn't make it easier to talk about these tough things, because you want to keep good relationships, and I think there needs to be a very good balance of knowing each other, of accepting each other, but also having a professional role. It's not so much about liking each other, if you understand what I mean.
Yes. Yeah. Okay. There were just a couple of other comments about studies that are currently underway by EONS into patient safety, but no other questions at the moment, David.
Okay, so we proceed, I suggest.
No.
Okay, so let's now talk and turn to strategies for improvement. And I think it's worth noting that cancer care has certainly done a lot in recent years to improve safety. But my question is, are we focusing on the right measures and the most effective strategies? And I think it's important that before we talk about this intervention or that intervention and this warning label and that new protocol, if we think of or conceptualize the character of different improvement strategies. And what you see now is a model of hierarchy of effectiveness of interventions to modify behavior. And as you can see, interventions could be people-focused or system-focused. And typical person-focused interventions are education and training, rules, policy, warnings and labels, whereas typical system-level interventions are culture change, big word, and very important, forcing functions, constraints, equipment, and environmental redesign. And the more system-focused interventions are, the stronger are they. Their effectiveness is high, but unfortunately, there's also a lot of effort required. Whereas people-focused interventions usually need less effort. They also need effort. That's not to say they're easy to implement, but they are usually less effective. And from a human factors perspective, person-based strategies are weak actions. For example, to have an impact, a warning label needs to be read, it needs to be understood, it needs to be acted upon every single time a person is using a drug or an equipment or whatever. And so they place heavy cognitive burden on staff under working very complex and demanding conditions, and therefore such actions are deemed unreliable. Of course, these interventions and different levels are also connected. For example, education and patient safety is likely to impact on culture and vice versa. And we certainly need all of these levels, and no single strategy will be sufficient, I think. However, I think in healthcare compared to other industries, if you want to use that word, is that we tend to focus too much on raising awareness of staff and too little on the systems in which work is done. I have the experience, and maybe you and the audience share that far too quick, far too often when we see a safety problem, our response is like a reflex to say, oh, staff needs to be educated again. We should put a poster on the wall that states, be aware, concentrate, focus on your work, and so on. And but you know, humans are limited in being aware all the day, all the time, no matter what. So let's apply this model to some examples in cancer care. As I said, strong and effective actions are those targeted at the structural, technological, and environmental conditions. And a very good example from oncology is the dramatic problem of wrong application routes with vinca alkaloids like Vincristine. These drugs should never be administered intracerebral through lumbar puncture, and the very best way to avoid this very severe error is to make the application route simply incompatible. And I show you an example. So this Vincristine should never be prepared in a syringe for adults or pediatric patients. The product should be manufactured or prepared in a small volume mini bag for intravenous infusion, so they simply cannot be connected to the intrathecal route. And to me, this seems like a very simple solution, given that we have already seen at least 200 or 250 deaths worldwide. Still, practice has been very reluctant in adopting these rules. In many settings, I know, even here in Switzerland, Vincristine is still delivered as a syringe, and focus is laid on rather weak actions like warning labels and protocols, procedures. And that's why in 2016, the US National Comprehensive Cancer Network launched a campaign named Just Bag It. You see the buttons on the slide to overcome the use of Vincristine in syringes. And if you want to participate, you can go on their website and sign up with your hospital or your oncology office. Other examples for strong actions to improve safety are related to the severe problem of interruptions during high-risk procedures, such as medication verification. And interruptions and distractions are a very common phenomenon everywhere in healthcare, but are problematic, of course, in complex care settings in particular. Research indicates that interruptions increase the likelihood of clinically relevant error to a large extent. You see the figures on the slide. And oncologists, for example, are frequently interrupted during their medication ordering processes. In this study, 8 interruptions per hour writing medication orders. Nurses are, of course, chronically interrupted during chemotherapy administration, and also frequently interrupted while performing safety critical tasks, for example, drug verifications. So in particular, during the times and seconds and minutes of the day where they need very much high level of concentration and cognitive work. And to me, it's really alarming to see under which unsafe conditions such critical tasks are performed. In a recent study, we surveyed oncology nurses about their double-checking practices, and we asked them which factors frequently interfere with performing a good double-check of chemotherapies. And to me, these results are really alarming. Nearly 60% mentioned noise and poor illumination as frequent hazards to their work. And that is simply to say they're performing double checks under inadequate environmental conditions. And we can hang up a poster or a warning, whatever, saying you need to concentrate, you need to focus, you need to be aware. If you simply have no light to read, that won't work. It simply won't work. And 80% in our study reported that interruptions and distractions commonly interfere with a double check. So what can be done to reduce those interruptions during safety relevant tasks? I don't have the $1 million answer, but I have some suggestions and idea. Clearly, we need some strong interventions to reduce noise and vulnerability to interruptions. They are a serious threat, and examples that have been tried in practice include the installation of safety zones, quiet zones, and other changes to equipment and environment. For example, you see on the slide a so-called verification booth, which was used in one study to provide nurses with a physically distinct quiet space to conduct verifications at computer stations. And the first results of studies show that these interventions can be quite effective if, and that's of course important, if they are sensitively implemented in the workflow and clinical process. You certainly have to ask, why are these interruptions so frequent? What is wrong in how we organize work? If it's required that somebody who's checking a chemotherapy needs obviously to be interrupted 5 times, 6 times, 7 times. Obviously, we are organizing care not very optimal. But no matter what redesign of structures and environment, and I think there's really a lot to do, the most valuable resource we have in healthcare is vigilant staff, and no equipment could finally substitute for that. And so we need to talk about culture. And again, I remind you to send in questions. We need to talk about culture. A strong and reliable safety culture is an important determinant of safe healthcare, of course. And this includes learning from errors, strong teamwork skills, and also speaking up towards colleagues and superiors when safety is jeopardized. And I want to return to the study we conducted among oncology staff in Switzerland. And as I said earlier, we saw that staff are very frequently concerned about patient safety. But the question is, what do they do with their concerns? Do they communicate about them? Do they point to others making an error, for example, or breaking rules? Or do they keep their concerns simply for themselves? And in fact, the majority of responders reported at least some episodes of remaining silent and withholding their safety concerns. For example, 50% of nurses and doctors said they said nothing to others about potential patient safety problems they noticed, and even 37% said they remained silent when they had information that might have helped prevent an incident. Again, important predictors for withholding voice are a low level of psychological safety at the unit where one works. For example, not feeling supported by superiors when you raise your voice. A low hierarchical position with strong authority gradients, and a high level of resignation and frustration. And that's something we see quite often, in particular among nurses, also in junior doctors, but in particular in nurses, the feeling that, oh, I've said 5 times something about breaking rules, nothing changed, I'm not going to say anything again because it simply doesn't make a difference. So we not only have to talk about speaking up, but also we have to talk about the consequences of speaking up. We have to talk with those people who receive an episode of speaking up. What would be an appropriate reaction to a nurse saying, hey, you are breaking a safety rule? So in conclusion, we need interventions that address speaking up behavior and increase the likelihood that staff will voice their concerns. As I mentioned earlier, we probably need a variety of actions. There's not the simple $1 million response to the patient safety problem, but we may need to make systems more reliable. This is also important because interventions and their effects interact. As I said, the system change towards more standardization, for example, will affect culture and vice versa. Finally, I want to point you to a very good recently published example of a study which excellently shows how a combination of technological interventions, process adaptations, and cultural elements work very good together and successfully increase patient safety. This is a study where the authors monitored chemotherapy errors at their unit using a process chart. I really recommend reading this study in full. And what they did is they sequentially implemented several interventions from different of our levels from our model, including, for example, a daily chemotherapy huddle, improvements to the preparation and delivery of intravenous therapies, headphones to reduce interruptions of clinicians ordering chemotherapy, and standards for administration of drugs throughout the entire hospital. And as you can see from the chart, the error rate decreases substantially over time. And key drivers for the success included error vigilance through the daily huddle and minimization of interruptions during ordering. And the improvement efforts were associated with significant and sustainable reductions in chemotherapy errors that reached the patients. So let me just briefly cover up what we've talked about. I started with outlining that cancer care is really increasingly complex, something that clinicians working in this environment often do not even recognize. But when you go on wards or on ambulatory infusion units as an outsider, then you recognize the very complex and sophisticated system of care provision. Errors and preventable adverse events are frequent, even in cancer care. Both patients and staff are concerned for safety, and that should be really have a meaning for us, that patients are concerned for safety. Systems-oriented strategies often require more effort but are much more effective. So I really invite everybody to think about possible systems-oriented strategies at their environment. And staff is, of course, and remains the essential safety resource, but often works under highly unsafe conditions. And it's these conditions we have to tackle. And we need combinations, I think, of cultural changes, careful design of environment and equipment, and then we can achieve sustainable improvements and make care safer. And yeah, thank you for listening to this point. And I'm asking Ella, do we have any questions in?
No questions at the moment.
Okay.
Hopefully we'll get some in over the next few minutes. Going back to one of the comments made earlier, which was there was a notice of a study undertaken by EONS at the moment in 4 countries called the RECAN project. So we're expecting results there in 2018 about patient safety attitudes. But I think it was a really interesting point you make about patience in this as well, David, because there's a lot of research and journal sort of time given to focusing on staff. Whereas patient involvement is something that's still in its early days, I think, in some ways, in patient safety. Is that something that you agree with? Like, from one of the statistics you said, that 16% of patients were aware of their errors. So there's something there to work with, maybe? The patients are increasingly becoming aware of safety?
Yeah, I think it is so. Patients are increasingly aware, and we should not forget that cancer patients in particular, they are experts because they have one real advantage compared to other patients. They usually receive the same procedures or processes over and over again. So they know how work should be done and how work is done. For example, in our interview study, many patients recognize that today they did it that and that way. Usually they do it this and this way. So they are quite good and sensitive in recognizing deviations from standards, if you want to, from standards of a particular hospital. And many patients in our study said, well, yes, they don't want to have blind trust. They want to understand what is being done with them. And if you are an active patient, you will see many risky situations. And I think we need to do everything we can to empower patients to talk about their impressions, their experiences, because they are valuable. There are other studies from outside the cancer setting where we see that the information and experiences patients hold about safety and errors is not covered in any other data type. These reports are not covered in adverse event studies or in the medical record. They are not covered in incident reporting. So I think we should really get to talk with patients about their experiences and impressions of safety.
Yes, that would be a very interesting piece of work to do. And I think the final point on the screen at the moment, the final bullet point you mentioned, sustainable improvement.
Yeah.
And that's what really struck me with your example from the VICE study, the run chart that you put up on slide 27, I think it was.
Yeah.
Now, this is fascinating because you see the change really starts occurring after 2 years or 18 months, whereas in the UK, if it wasn't working in the first 2 months, they would stop it. You know.
Yeah.
So I mean, is that something that's common? Do you think that we don't often give enough time to change in safety, that we expect results to be very, very soon?
Yeah, I think that's a common problem, and it is connected to my point of view with the idea many people have of culture. I often receive the response, oh, we can't introduce this intervention. We first need the culture. So there's obviously the idea somehow culture needs to change, and then you can put some interventions into practice. But that is not how culture develops. For example, everybody knows that if you are wearing your professional suit, you feel different and you will behave different. So sometimes it's a good idea to just start an intervention, even if you think you don't have the culture. It's not going to be accepted, because doing things differently will change how people feel and think about it. And good examples are, for example, the introduction of the safe surgery checklist into the surgical theater. Many surgeons said, oh no, we can't do that, a checklist, that's not our culture. And if you talk to them now, you have to get them to try it, right? You have to get them to try it. But then many say, yeah, doing this feels different, and that makes a change. And so I think really we need to have time for culture to develop and not start interventions over and over again every second day.
Yes. Yeah, that's a good point. Okay, so how long have we got now? Six.
I think we are nearly finished. Yeah.
Nearly at the end. I don't know if
Yeah.
there are no questions
Okay.
from anywhere else. So
Okay.
do we call it a day? I'll just
Okay.
give in time for any other questions, but
Yeah.
that's no, that seems to be it. So
Okay. Thank you very much for listening, and have a nice evening, everybody. Bye bye.